So I am provided with axial CT scan images at the level of the liver, and this is triphasic. I am provided with arterial, portal, venous, and delayed phase. On these images, I can appreciate that the liver margins are regular, normal, and texture is also unremarkable. However, there is heterogeneous specks of arterial enhancement involving right lobe of liver, and these are multifocal with internal hypodensity is also appreciated on arterial phase. And on portal venous phase, these multifocal lesions are showing washout as compared to arterial phase, and on delayed phase, these are also hypodense.
Yes.
Visualize portal veins and IVC are unremarkable. Fluid dilated vessels at splenic hilum can be varices, but I would like to see further images to confirm this finding. And visualize gastric curvature is also unremarkable. No ascites on these images can be appreciated. And visualized bones are also unremarkable. So to calculate my findings, these multifocal lesions are giving arterial enhancement and venous washouts and internal few areas of hypodensities are raising the suspicion of multifocal HCC. I would further go for history to see any underlying history of hepatitis B or C or any other factor that is precancerous for HCC. And also for tumor marker, alpha fetoprotein. And further MRI can also help us to measure the extent, and will be helpful in future to see the progression of the disease. And MDT, this should be discussed in MDT to further advise the treatment, whether chemoembolization or whatever. This should be decided in MDT meeting and proceeded accordingly.
Excellent, well done. So to evaluate liver lesion, the protocol, we should do pre-contrast images, arterial phase, late arterial phase, Part-2 venous, and delayed images. The first, we should comment about the background of the liver. Is it cirrhotic liver? Is there any significant hepatic steatosis? Because this will affect the pattern of enhancement of the hepatic lesions. Is there any hemochromatosis? So the background of the liver is very important. Here, the liver is cirrhotic. There is surface irregularity, more appreciated around caudate loop, mild hypertrophy of the caudate loop, prominent fissures. So the liver is cirrhotic. In cirrhotic liver, we have to exclude HCC or atypical HCC, cholangiocarcinoma, or metastasis. The HCC will be hyper-enhancing in arterial phase, and it will show washout in subsequent delayed images. The washout, it means the liver region will be more hypodense as compared to the background of the liver. The lesion here is ill-defined. It's not capsulated. Ill-defined, that means it is infiltrating. So hypervascular region, washout on the images in a background of cirrhosis. This is hepatocellular carcinoma, infiltrative.
These are the CT scan pelvis, axial images, axial and coronal images with oral and IV contrast. These I just want to see the lesion. There is a heterogeneously enhancing mass. Lesion is noted in the pelvic region, and
okay,
it's showing the mean density.
It is not enhancing. The mean density is 70.
Ma'am, Yes, ma'am. Okay.
Patient presented with acute abdominal pain. Patient presented in the emergency with acute abdominal pain, dropping in HP.
Okay. And there is a hypotensive areas noted in the pelvic region, and there is also some mild free fluid is also noted in the close vicinity of the uterus, and there is also a heterogeneous area is noted in the anatomical location of the right adnexal region, and
okay, I can guide you. I can help you in this case. This is right ovary, little bit congested, and this is left ovary. Again, this is right ovary.
I can't see your pointer.
Ma'am, can you please use the pointer?
Is it clear now?
No, the pointer is not moving.
Not moving, yes, ma'am. Yes, how this is moving.
Okay, this is right ovary. This is left ovary. This is right ovary here in coronal images. This is left ovary.
Yes.
Most of the ovaries, it's obscured by the surrounding abnormality. So what do you think? This is part of the uterus. Patient presented with acute abdominal pain, dropping in HP.
Good. Ma'am, it can be a ruptured ectopic if the patient has beta constitutive. And the other
what's this here? What's this?
And there is also ascites, yes, ma'am.
Okay.
Ma'am, this is ascites, likely hemoperitoneal.
Yes, exactly. Your differential diagnosis.
Dropping HP. Ma'am, first is ruptured ectopic, and other it can be torsion.
Do you expect to see hemoperitoneum with torsion?
No, ma'am. Actually, don't look. As for the DD, then I just do it.
Okay. We have here ascites. However, it's more hyperdense surrounding the ovary and almost encasing and obscuring the ovaries. It's very important to measure the density of fluid in the abdomen, because the density of a fluid in the abdomen suggests its composition. Is it ascites, simple fluid, bowel contents, thick fluid? Is it hemorrhage? Here it's hyperdense. Recent hemorrhage or acute hemorrhage, the density will be 30 to 45. However, clotted blood, the density will be 45 to 70 Housefield units. Here we have different densities. Here it looks a little bit hypo, and surrounding the ovaries, it's more hyperdense. So recent hemorrhage, 30 to 45, clotted blood is 45 to 70. All the blood products or seroma usually measure less than 30 Housefield units. So here we have ascites of different density. It's hyperdense surrounding the uterus and ovaries. On the left side, at the left ovary, there is a well-defined cyst here.
Yes, ma'am.
With tiny hyperdense foci. This hyperdense foci, it was in view of the presence of hemoperitoneum, it was reported as oozing blood, active bleeding. However, if we have pre-contrast, it will be very easy to differentiate between blood or even calcifications. And post-operative note confirmed the presence of oozing active blood from the left side. This is a case of ruptured ovarian cyst. So, in case of hemoperitoneum in female patients, you should think of ruptured ectopic pregnancy, and you should correlate with beta HCG. Other differential diagnosis, ruptured ovarian cyst. This is the most two important differential diagnosis of hemoperitoneum in female. Other differential diagnosis for hemoperitoneum, it could be ruptured aneurysm, or it could be acute hemorrhagic pancreatitis, and it could be spontaneous bleeding, especially in patients with coagulopathy. The most important, you have to exclude ectopic pregnancy, and you have to exclude ovarian cyst structure.
And there's a question, can you think of trauma in this case?
Yes, sure, but there is no history of trauma.
All right. And can it be ovarian hyperstimulation syndrome?
No, because the main findings here is the hemoperitoneum. In ovarian hyperstimulation syndrome, you will see bilateral multicystic ovaries. Nothing will explain the hemoperitoneum in ovarian hyperstimulation syndrome. The main findings here in emergency case is hemoperitoneum.
I am provided with the grayscale ultrasound images through the level of pelvis, showing the bilateral ovaries and the uterus. I can appreciate that both the ovaries shows large, well-defined cystic lesions throughout the ovaries. The size of the bilateral ovaries is enlarged. However, I cannot see any thickened or echogenic increased amount of parenchyma within these ovaries, ovarian tissue. All these cystic structures are large in size and are occupying almost all of the ovarian tissue. In the image to the level of uterus, I can see that there is mild amount of fluid within the endometrial cavity, and the
only fluid within the endometrial cavity.
Yeah, there's mild amount of fluid in endometrial cavity.
Do you think this is normal appearance of endometrium?
No, endometrium is thickened, heterogeneous with internal hypoechoic areas.
With internal hypoechoic areas?
Yeah,
it means hypoechoic areas, it means cystic changes. Agree?
Yeah, cystic changes, yes.
Okay.
And there are cystic changes in the uterus and with the bilateral ovarian, multiple ovarian cysts. Most likely this is a theca luteal cyst in the both ovaries, with the uterus showing multiple hypoechoic areas which are giving somewhat snowstorm appearance, suggestive of molar pregnancy with theca luteal cysts.
Well done. So we have here bilateral. Okay.
So we should correlate with the
what's the differential? What's the differential for the bilateral ovarian cysts?
Yeah, this differentials may include ovarian hyperstimulation syndrome with this large size cysts, and with maybe this is endometrial hyperplasia with that.
Yes.
You're trying.
Well done. Okay. So by ultrasound, we have bilateral enlarged multicystic ovaries. The cysts are classically thin-walled and have clear contents, no solid component. So the differential diagnosis in bilateral ovarian cysts could be ovarian hyperstimulation syndrome, and in this case, we have to correlate with history of ovulation induction. Second differential, mucinous ovarian malignancy. However, in case of mucinous ovarian malignancy, we expect to see some solid components, irregularities, nodular septations, and we should correlate with ovarian tumor. So the third differential is bilateral theca luteal cyst, which is associated with gestational trophoblastic disease and occurs due to ovarian stimulation by the high level of beta HCG. So in this case, we have to correlate with serial beta HCG. The endometrium here is thickened, occupied by echogenic mass, which shows multiple cystic changes. So this is the case of gestational trophoblastic disease or molar pregnancy with bilateral theca luteal cyst. And this is the abnormal images, okay?
These are multiple axial sections from contrasting on CT through liver and pancreas. The pancreatic head and body and tail are enlarged, and However, no peripancreatic fat stranding seen, no enlarged pancreatic duct seen, no evidence of any calcification seen, no peripancreatic collection seen. So I would like to know the pancreatic enzyme status. Pancreas is slightly enlarged. So this is this can be autoimmune pancreatitis.
Well done.
I would like to see the other associations of autoimmune pancreatitis, right? Orbital pseudotumor, renal thyroiditis, and mesenteric fibrosis, etc.
Okay, well done. Agree, this is a case of autoimmune pancreatitis. This is normal appearance of the pancreas. We have here diffuse enlargement of the pancreas with loss of definition of pancreatic clefts. This is the normal appearance, and this is the abnormal. So it is diffusely enlarged, little bit hypodense with loss of definition of pancreatic clefts. Result in sausage-shaped pancreas. This is sausage-shaped pancreas. In autoimmune pancreatitis, there is minimal prepancreatic fat stranding, unlike interstitial pancreatitis. Here in autoimmune, there is minimal prepancreatic fat stranding, and usually the inflammation not extending into the mesentery or pararenal fascia. This is in case of autoimmune pancreatitis. So in case of autoimmune pancreatitis, you will see diffuse enlargement of the pancreas, sausage-shaped of the pancreas, with minimal peripancreatic fat stranding, and the inflammation is not extending into the pararenal fascia or lateral conal fascia as well. In addition, here there is very tiny hypodense rim. This is very characteristic of autoimmune pancreatitis. This hypodense halo, very characteristic for autoimmune pancreatitis.
Ma'am, please, where is the halo? I am unable to see this.
Look, this tiny hypodensity here and here, it's not continuous. Look, this area, this hypodense line here.
Yes, ma'am.
So this is case of autoimmune pancreatitis, and it's a form of chronic pancreatitis, and distinguishing this entity from other forms of pancreatitis is very important because steroid treatment is effective, both in reversing morphologic changes and also returning pancreatic function to normal.
There are multiple images of axial section images of CT abdomen pelvis with contrast. Here I can appreciate that at the level of the gallbladder, there is an area of air. I can appreciate that there is gallbladder is not visualized. However, there is area of bowel loop.
Okay, I can guide you. This is second part of the duodenum. And this is location of the gallbladder. So, this is gallbladder fossa.
So I can appreciate that there is an abnormal communication between the lumen of second part of duodenum and gallbladder, resulting in air within the gallbladder. And there, however, rest of the liver and pancreas appear unremarkable. I cannot appreciate any pathology within the pelvis. There is no pee fluid within the pelvis. No evidence of pneumoperitoneum is noted.
Okay, what do you think about this?
A hyperdense focus is noted within the bowel. Within the bowel, that might be the gallstone.
Yes.
So So concluding my findings of presence of gallstone.
What about this tiny hypodensity? It's air.
It's air. Okay. So the findings of the presence of gallstone within the gut, resulting in the pneumobilia and air within the gallbladder is suggestive of gallstone ileus.
Well done. So this is gallbladder fossa, and this is gallbladder. The wall here is edematous. The lumen of the gallbladder is seen communicating with the lumen of the duodenum. So this is cholecystoduodenal fistula. The stone here is seen at the distal iliac loop. In addition, this tiny air fossae is consistent with pneumobilia. So this is regular triad, which is consistent with gallstone ileus, which is uncommon cause of mechanical small bowel obstruction, and it is a rare complication of chronic cholecystitis. It occurs when a gallstone passes through a fistula between the gallbladder and small bowel and become impacted near the commonest location. It will be impacted near the ileocecal valve. This is the commonest location at the terminal ileum. However, other locations still, you can see it at proximal ileum, jejunum, or even colon. So this is case of gallstone ileus, regular triad.
These are the CT scan images of abdomen, contrast enhanced images. Axial and coronal deformated images are being provided at the level of abdomen and also at the lower abdomen. Okay, multiple dilated gut loops are seen throughout the abdomen with the air fluid levels. I can appreciate the massively dilated gut loop in the region of the left hypochondral region, which is the two gut loop segments conglomerated. In lower abdomen, in the midline, a dilated gut loop segment, predominantly this is of sigmoid column, is giving the enhancing wall.
What do you think? What is the cause of obstruction? There is no previous. What do you think? What is the cause of obstruction? There is no previous history of surgery.
Madam, the gut movement in the left hypochondral region, which appears to be two gut segments in addition. So differential can be the internal or however the distal gut loops are also dilated, and I can see some hyperdense foci in the somewhere in the lumen of the gut. Probably they are the feculates, or they can be multiple.
Okay, where is the zone of transition?
Zone of transition. Okay.
Do you think large bowel is dilated? This is sigmoid. This is sigmoid. Okay. It is collapsed. It is not dilated. Okay. And here, this is part of the ascending colon. So most likely, large bowel is not dilated. So mainly, we are dealing with high-grade small bowel obstruction. The zone of transition at this area, this is dilated segment, then collapsed segment. So this is the zone of transition. We don't see frank enhancing masses at the zone of transition. However, at this area, there is mottled gas pattern. Suspicious for, any idea? Viscera. Viscera, accumulations of indigestible contents within the GI tract.
Right.
And this is 5-2 viscera. It is indigestible food material.
Food material, yes.
Okay. Yes. So this is case of viscera with high-grade small bowel obstruction.